Thank you so much. It's really great to be here, be it virtually. So hopefully at one point we can go back to face meetings, but I think this will do. And I think people are doing a great job in trying to get it done. So indeed, today's talk will be about functional respiratory imaging in COVID-19.
There we go.
I
I think
think
I
I
don't
don't
have
have
to
to
convince
convince
anybody.
anybody on this conference that lung diseases are quite complex. I've been discussing them for decades. They're quite costly, and really they're a global phenomenon. This pandemic is raging throughout the entire world, I would say. And unfortunately, this is an image I think we've seen too much of the last 2 years, where physicians really struggle to select the right treatment for the right patient. Due to the complexity of the disease, the lack of good diagnostic prognostics, and we don't really understand how these drugs work in lung diseases. So it's really hard to optimize the treatment selection for individual patients. And if you think about it, in respiratory medicine, we're used to measuring something at the mouth, and then we provide something at the mouth, or a systemic drugs, or inhaled drug, or a systemic drug, and we hope the magic happens inside. And sometimes it does, but often it really doesn't.
Set out about 15 years ago to develop
What we now call functional respiratory imaging. And functional respiratory imaging starts from the conventional low-dose, high-resolution CT scan, so it can be applied in any modern hospital. And as you know, the typical way of looking at a CT scan is having a radiologist scroll through these 2D images, looking for abnormal patterns. So it's quite a subjective approach. If you have 5 radiologists looking at the same scan, they come up with slightly different interpretations. So it's quite subjective, and it's not very scalable. So what we did with functional respiratory imaging is we convert these 2D images into 3D reconstructions of the anatomical structures. So we look at airways, blood vessels, lung volumes, emphysema scores, and so on. And if we have an inspiratory expiratory scan, we can make these images come to life. So we can look at regional ventilation using the methods from aerospace engineering, resistances. We can also look at these aerosol deposition characteristics. So using the flow simulation approach and the CT scans to really make it personalized, really make it patient specific, we can assess the regional deposition of inhaled compounds and understand where those drugs end up as a function of the disease, the inhalation profile, and so on. So you can really understand where the drug is going. And to this previous speaker's point, you could use a type of technology to try to optimize a targeted drug delivery if you want to have it in the larger or the smaller airways. This is a good way to try to understand what really drives deposition. So FRI provides a very comprehensive set of parameters that allow us to understand lung diseases in more detail, and we'll see how this applies to COVID in the next few slides. And if we use the technology on CT scans taken at baseline, and then after the administration of a treatment, the effect of the treatment, whether it's bronchodilation, vasodilation, anti-inflammatory effects, and so on. So by doing this, using it as a diagnostic tool and a treatment assessment tool, in the end, we're hopeful that we can use it as an optimal treatment selection tool, really paving the way for personalized medicine. So what about COVID-19? So quite early on in the pandemic, it was clear that there was an important vascular condition to this disease. So what we started doing was trying to collect images from around the world and then really perform a 3D reconstruction of the pulmonary vasculature and then look at the subcompartments. So what you see here is actually a healthy volunteer where we did a 3D reconstruction of the pulmonary vasculature, and we subdivided into 3 categories: the BV5, which is the blood volume with a cross-sectional area below 5 millimeters, so the smaller vessels. The blue zones are the larger vessels with a cross-sectional area above 10 millimeters squared, and then the yellow zones are the mid-sized vessels between 5 and 10 millimeters squared. So essentially what you're doing is you're assessing how the blood volume that is visible in the CT scan, how that is distributed over the different sizes of the vessels. So here, if you look at the blue line, these are about 100 healthy volunteers. You can actually see that distribution, the standard deviation on that distribution is quite limited. which biologically makes sense. So the way the blood volume is distributed over the different generations is irrespective of age, gender, height. The total blood volume, of course, differs with age, gender, height, but the distribution, if you're healthy, is pretty similar amongst that population. Now, if you look at the green line, you see that's about 100 COVID-19 patients. You see a clear shift from blue line, characterized by vasoconstriction occlusion in these smaller vessels, and then compensatory vasodilation in these mid-size and these larger vessels. You can also see this visually. So on the left-hand side, again, a healthy control. See a lot of these red zones. The right-hand side, acute COVID-19, you see a lot of these red zones disappear. So it's not that the blood vessels disappear, but we believe likely due to endothelial damage caused by the virus, you have microvascular occlusion leading to upstream dilation. So you don't see a lot of smaller vessels because they become dilated because of downstream obstruction. The upstream dilation makes them larger. So how does this relate to the need for oxygen, for instance? So here you can see that in a healthy population, about 55% of the blood vessels that you see belong to this BV5 category. So are millimeters square in diameter or in cross-sectional area. You see in these COVID-19 patients that this BV5 fraction is significantly reduced, and it's further reduced in a population that requires more oxygen to remain at a certain level of saturation. We also see that it's correlated with the alveolar arterial oxygen gradient. So the lower the BV5, the higher this gradient, which is a measure for VQ mismatch, and we'll talk about it more in the next few slides. And we also see a correlation with lower BV5 and lower partial oxygen pressures. So there's a big debate still ongoing whether COVID-19 is different than non-COVID-19 ARDS, especially amongst intensivists. Is quite an intensified debate. So you probably know ARDS, acute respiratory distress syndrome, is characterized by flux of inflammatory cells in the alveoli, impairing the gas exchange. So what you typically do is you intubate the patient, use increased pressures, so fairly high pressures, to kind of push these cells back to the other side of the membrane, trying to clear and recruit the airways. So typical ARDS shows up in scans with ground glass opacity, so the grayish areas, and consolidation, that's where it becomes completely white. So that's a typical way of assessing ARDS visually, and I'll show you in a few slides that it's very hard to assess the actual blood vessels, the blood volumes. And so a radiologist in a visual read usually limits the assessments to the ground glass opacity and the consolidation. Now, interestingly, if we look at these blood vessels that you can measure with the quantification tools, you see that in this case, the red line is non-COVID ARDS. So you do see that it also differs from the, but we don't see this severe vasoconstriction, vasoocclusion in these smaller vessels, like we typically see in COVID-19. So it does appear to be, from these initial assessments, that there is a difference between COVID-19 and non-COVID-19 ARDS. And why does it matter? It probably matters quite a bit. So this is a study that we published in Thorax a few months ago. So what you see here on the left-hand side is the BV5 as a percentage of total blood volume. And you do see that these non-COVID ARDS patients are pretty much at the level of the healthy controls. So we had non-COVID ARDS patients scanned at baseline and at 20 centimeters of PEEP, so with increased pressures. On the right-hand side, you see the BV10. So these are the larger blood vessels. So what happens if you increase the pressure? Pushing blood away from these smaller vessels into the larger vessels, which probably is okay if there's not an underlying vascular condition. But here you see that the COVID-19 patients already have a significantly reduced BV5. So likely if you use too much PEEP, if you're too aggressive with the pressures, you close off these vessels even more, probably making it very hard to get any oxygen in the blood. And we believe that's likely why, especially in the first wave, we saw very high levels of mortality, especially in the elderly populations that were intubated, 60-70% mortality figures, which is extraordinarily high. So we published this. There was an editorial written about this paper saying, to conclude, Tillai et al. Showed visibly well that severely ill patients with COVID-19 have redistribution of the pulmonary blood flow. We're looking forward to hearing more from this FRI technique, ideally combined with more radiological and within the context of a well-designed trial. So we kind of acted on this recommendation. So we set out to do a larger clinical study to assess whether BVX, so the blood vessel volume derived from a CT scan, whether that parameter is predictive of intubation or death. So we enrolled about 508 patients. We included COVID-19 positive and negative patients, a multi-center study, 10 hospitals. And we took the HRCT scan within 24 hours of hospital admission. And we tried to predict whether a patient would die or would require intubation. We corrected for anything that could influence the outcome, such as the anticoagulant treatment, steroids, remdesivir, and so on. And if we look at the range of disease severities, we indeed saw patients that were very severely affected in terms of the pulmonary vasculature with very low BV5s, like patient A here, only, and so not a lot of red zones anymore. Patient B was more in the normal range, about 55% in BV5. And if you look at the odds ratios, you could see that effectively for the COVID-19 positive group, the BV5 becomes quite predictive for mortality, the intubation, or the combination of both. And especially for patients with very low levels of BV5, so below 25%, you would see odds ratios of about 6 in terms of mortality, so quite severe. Interestingly, in the COVID-19 negative group, we didn't see these significant levels. So again, indicating that this vasculopathy seems to be a hallmark feature of COVID-19. I think this is an important graph. So this is a correlation between the small blood vessel volume measured from the CT scans and the opacification. So the typical way of assessing of the viral pneumonia. And then you see there is a correlation. So the more opacification you see, the lower the BV5. But you do see on the left-hand side of the graph, there's many zones where there's no opacification. So where radiologists would say this is a normal lung, this is clear, where there's actually a significant reduction in BV5. So it can be that areas look normal in the scan, but still are significantly affected in terms of the vasculopathy, in terms of vasoconstriction, vasoocclusion. So using age and BV5, we were able to achieve accuracies of about 82-85% to predict intubation or death. So that allows us to make these graphs, as you see here on the right side. So as a function of age and the BV5 extracted from the patient's scan, we can assess the probability for adverse events. And you see the level between, or the slope between 20 and 40% is. It's important to know where the patients lie. So especially in the pandemic where resources are limited, this type of tool to triage the patient becomes quite useful. And nowadays with the cloud computing, there's ample computing power, so these assessments can be turned around quite quickly. In about 20 minutes, this type of information can be available to the physician. So this paper was published in the European Respiratory Journal. An editorial was written again about it, and it states, time will tell whether quantitative CT analysis, including artificial intelligence and machine learning, can or indeed should be integrated into routine respiratory practice. The present study represents definite progress, building on a steadily growing body of work, suggesting that this time may be approaching. So it's encouraging to see that there is an increased adoption of this type of technology, especially in clinical trials, and it's increasing now in clinical practices. What about ventilation perfusion mismatch? Another big debate that's ongoing, where hopefully this type of technology and data could also help to facilitate some of those questions. So we were able to acquire an interesting data set where we had inspiratory and expiratory scans in COVID-19 patients quite early on in their disease. So this was the first wave. The data came from Brazil, where they were using CT scans to kind of diagnose the disease, because at that point PCR tests weren't widely available. But if you have inspiratory expiratory scans, we can also look at regional ventilation. So you can look at the expansion of the lobes. You can look at the regional changes in voxel positions, which reflects regional ventilation. And of course, if we combine this with the vessel assessment, we can have an indication of VQ matching and VQ mismatching. So we can come up like this, where on the horizontal axis, we have the lobar ventilation expressed as percent predicted. So 100% is normal. On the vertical axis, we have the BV5 as percent predicted. So the unit line is the VQ matching line. So if you're below the line, you're in the dead space ventilation zone, and you're above the line, you're actually perfusing gasless tissue. So it's quite clear that this disease is mainly characterized by dead space ventilation. So it seems that the ventilatory aspect in the early stage of the disease is still relatively well preserved, but it's very much a vascular issue that causes the problems, rather than that we're perfusing zones without ventilation. So it's very much dead space ventilation that we encounter in COVID-19. So if you look at individual patients, you can see, for instance, in this case, on the right-hand side, you see the ventilation graph. So red indicates high ventilation. So you see for this particular patient, lobes seem to be well ventilated. But then if you look at the blood vessels, it also seems that in those lower lobes, we see a lot of blue. So we see a lot of dilation of these larger vessels. We see constriction of these smaller vessels. So we can hypothesize that maybe because it's a respiratory virus, so the zones that are well ventilated are also more exposed to the virus, leading to regional change in the severity of the vasculopathy. Could be one of the cases, but in any case, you can use this type of technology to really drill down on these questions and get hopefully more answers that lead to better clinical outcomes. What is potentially something we can do about it? So this is not in COVID, this is in COPD-PH, where we assessed inhaled nitric oxide as a vasodilator. So you can influence the blood vessel volume. So in this case, you can see that if you take a CT scan during the administration, oxide, so that's the green line, you see that compared to the baseline, which is the red line, you do see a shift characterized by an increase in the blood vessel volume in these smaller vessels, and a shift, so a reduction in the volume in these larger vessels. So the color codes here indicate green is vasodilation, and then the red, which is mainly in these larger vessels, indicates a reduction in the vessel volume. So these are other COPD patients, so you can appreciate the heterogeneity of the disease, but also the heterogeneity of the treatment effect. So it's good news that you can actually influence the vascular component of the disease, not only for COVID-19, but also for other lung diseases, not in the least COPD, where I think there's a significant portion of the patients not being treated today, their underlying vascular condition not being treated today because it's not very well diagnosed. But if it's diagnosed, to treat, there are options to improve the condition. Another burning question, are we in it for the long haul? And unfortunately, I think the answer is yes. The first scans that we receive now from these long haulers do indicate, not only from the vascular side, but also from the airway side, that we do see sustained bronchoconstriction and vasoconstriction. So here, these are the airways, so not the blood vessels, but the airways. So visit 0 is the hospitalization visit, where you do see a significant reduction in the airway volume, so significant bronchoconstriction. And it takes weeks, months to even get close to the more healthy levels. So there is a long-term inflammation in these patients. So, and the tricky part is, if you take a CT scan, visually those airways don't look that dissimilar. But again, if you measure, in this case, for instance, for this patient, the airway volumes are only 31% predicted. So a 70% reduction, which is quite substantial. What happens to the vessels? So this is the BV5 we discussed at great length. So we know in the acute phase, it is significantly reduced, as you see here. During recovery, we do see an increase in BV5, so you do see that the parameter tends to move more towards the normal zone, which is good, but it takes a long time to get there. The mid-size vessels, so the yellow zone, the BV5 to 10, it's interesting, it moves out of the normal zone, so you do see that the signal or the signature moves towards the different zones, and then the larger vessels, they also tend to move towards the normal zone. So I think in here, if you visually see the long-term COVID, not as severe as acute COVID, but not quite there. So I think we can say there's still a tremendous unmet need in respiratory medicine to better understand both the lung diseases as well as the treatments. We're hopeful that new technologies such as FRI can provide some assistance in meeting those challenges. I think AI and deep learning will revolutionize medicine in general and also respiratory medicine in particular, but it's very important to always link these new technologies to improved clinical outcome such that we can use it sustainably in the clinical practice. So thank you very much for your attention. Looking forward to any questions you might have.
Thank you, Jan. Very interesting and very prescient talk. I think very indicative of our time, as we can't avoid the COVID theme, but certainly a lot going on. You actually answered one of the questions that I had towards the end of your presentation, which is around how this may manifest in long COVID versus acute COVID. But this probably links in with one of the questions that we've had online, which is in relation to, how could you see FRI, them being used to help select an appropriate therapy for treatment in COVID patients, given the impact on pulmonary vasculature?
It's a very good question. I think the long COVID is acute COVID as well. It's a very challenging disease. I think one of the big advantages of using an image-based approach is that you can really quantify the vascular involvement, the parenchymal involvement, and the airway involvement, and really see what drives the disease for that particular patient. Because currently we either use spirometry or even further derived measures such as symptoms or exercise tolerance. So it's quite unclear whether it's really driven by an airway element, a vascular element, parenchymal element, or a combination of that. So I think going forward, just understanding the distribution of airways, blood vessels, parenchyma already allows the selection of better treatments. So we hear a lot about inhaled corticosteroids. They probably work well in patients where the airway side of things remains an issue for a long period of time. I do think the good news is that there are a lot of drugs in pulmonary arterial hypertension that could potentially be reused both for acute and long COVID. I think a lot of things failed because we studied them at the very end stage of the acute disease, right? So it's all trying to reduce the hospitalization stay. I think at that point in time, when everything is wrong, when the lungs are filled up with the cells, where the airways are constricted, the vessels are constricted, I think there's very little that really helps. But I think just the fact that you can quantify the relative weight of the different elements could already lead to potentially the selection of better treatments.
Thank you. And now I'm going to hand over to Omar, who I think has got several questions as well, certainly from the clinical aspect.
Yeah, no, we've got some questions coming in, so we'll try and address some of them in the remaining time. So very nice work, Jan. So we're talking about blood vessels, and you're now in the area of blood vessels. And we know from physiology that when you have underventilated lungs, as you show, you have redistribution of blood flow. So we've known that for a time. The scans are done supine, and patients walk upright. And so so a recovering patient, how can we understand what happens with the blood flow and the effect of gravity, and then relate that to functional outcomes of a patient? So erect CT scans and erect imaging versus supine, Jan, and then relating that to the actual functional day-to-day living of a patient walking up a stairs or walking outside to get the shopping.
Good question.
I think that's a limitation of today's
scans, that they're all supine. So we kind of have to approach it a little bit as a surrogate measure to a certain extent, because it's not the actual scenario or the actual situation when you're upright. Having said that, if you look at the healthy population, one thing that we always look for is parameters that are well behaved. And in this case, as I've shown, the distribution of the blood volume over the different generations is quite well behaved in this healthy population. So using that as some sort of reference, you can try to understand where it goes wrong in patients in terms of deviations from this healthy status, either in terms of ventilation or vessels, and then start linking that with their symptoms. We've seen this in, for instance, COPD, where you do pre and post valve placement or coil placement, that the CT-based, even though it's done in a supine position, does correlate with symptoms, 6-minute walk test, exercise tolerance, and so on. So even though it's a limitation, so if we had an upright CT scan, that would be probably interesting. But I think it's already quite informative to look at the quantification of the supine images.
Michelle.
Thank you. Yes, and we've probably got time for a very, very quick question before we finish. Really exciting technology available that's being applied very contemporaneously. Is this actually being used in any clinical care setting? And how are the results comparing to any other trials that are going on? And can it be you may have already answered it, can it be then used to select the best therapy for COVID treatment?
So it's being used more and more. So we do have FDA clearance now since a year or so in the US. So we have a few sites that are rolling it out now and using it in a few other IRB approval in Europe as well. So the real world evidence is trickling in. And it's interesting to see the variety of patients. At this point in time, we're at the stage, I think, where we're generating the data in the clinical trials, and we're implementing the technology in the clinical practice. So it'll take a little while to kind of merge the two, to really link the knowledge from the clinical trials to what we see in the clinical practice. So currently, you're a little bit at the mercy of the quality of the physician. So the physician should be able to interpret the data from the CT scans and link it to the treatments they know at that point in time while we're generating more data in the clinical trials. But I think the momentum has started. So going forward, I think there will be much more data coming from our group, from other groups as well in the imaging. I think for physicians in the clinical practice will provide much more guidance, because now I think everybody admits there's a lot of trial and error in clinical practice now. So hopefully this type of technology provides more guidance in what type of treatment is more optimal for the individual patient.
Thank you. Thank you, Jan. That was a really interesting talk and great work that's going on.